Welcome to the weekly neurology deep dive. This is where we really get into one significant publication, unpack its findings, its implications, basically giving you a focused update. Just a quick reminder before we start. This deep dive is strictly for educational purposes. There's no commercial goal here. It's our summary based on the specific paper provided, and we really do recommend you check out the full original article for all the details and context.
Absolutely. So today, our focus is a new phase 3 trial. It's looking at Upadacitinib as a potential treatment for giant cell arteritis.
And we're basing this on the recent paper in the New England Journal of Medicine, specifically the one detailing the SELECT-GCA trial. Our goal here is to pull out the key data, the trial specifics, efficacy, safety, and maybe most importantly, the practical points for managing giant cell arteritis.
Okay, let's just quickly set the scene with giant cell arteritis. As you know, it's that systemic vasculitis hitting the large and medium arteries, mostly affecting older adults, typically over 50, mean age usually around 70.
And the classic presentations: headaches, scalp pain, that jaw claudication, and critically, the vision issues, which can lead to permanent loss. Plus, the association with polymyalgia rheumatica is quite common.
Exactly. Now, treatment, traditionally it's been high-dose glucocorticoids. They work initially, but we all know the downsides, particularly in this older group. Significant risk of toxic effects with long-term use, and relapse rates are just really high. Somewhere between 50 to 80% of patients flare up when you try to taper the steroids.
So that persistent need for effective options that let us spare the steroids, that's a major hurdle in managing giant cell arteritis.
And really, until fairly recently, apart from glucocorticoids, Itolizumab, the interleukin-6 receptor inhibitor, was the only other specifically approved therapy. It really highlights how limited the options were.
Which brings us to Upadacitinib. The paper introduces it as a selective Janus kinase inhibitor, specifically targeting JAK1.
That's right. So by blocking JK1, Upadacitinib disrupts the signaling pathways for some key pro-inflammatory cytokines, things like interleukin-6 and interferon gamma. These are thought to be involved in the pathogenesis of giant cell arteritis, so the idea was targeting this pathway might help.
Okay, so how did the SELECT-GCA trial actually test this? What was the study design?
It was set up as a phase 3 randomized, double-blind, placebo-controlled study, the gold standard for this kind of evaluation. And it was a big global effort, 100 sites, 24 countries involved.
And who were they enrolling? What kind of patients?
They took adults, 50 years or older, who had either new-onset giant cell arteritis or relapsing disease. A crucial point was diagnostic confirmation, either a temporal artery biopsy showing giant cell arteritis or imaging evidence from ultrasound, PK, CT, MRI, or angiography.
And active disease was a requirement.
Yes. The disease had to be active within 8 weeks before the baseline visit. That meant clear cranial symptoms or polymyalgia rheumatica symptoms, or both, plus elevated inflammatory markers, an erythrocyte sedimentation rate over 30 mmHg, or a C-reactive protein of at least 1 milli-GDL, or both.
Got it. A clear clinical picture backed by objective markers. What about their steroid use before entering the trial?
Patients had to have received prednisone or an equivalent at 40 milligrams daily or more at some point. And at the time they were randomized, they needed to be currently taking between 20 and 60 milligrams daily.
Were there any important exclusions we should know about?
Yes, a couple of key ones. Anyone who had previously taken a JAK inhibitor was out. Also, patients who had had a disease flare while they were already on an interleukin-6 inhibitor were excluded. This kind of focused the study population.
And the randomization, how were patients assigned?
It was a 2-to-1-to-1 ratio. So the biggest group got Upadacitinib 15 milligrams once a day. Then there were two smaller groups. One got Upadacitinib 7.5 milligrams daily, and the other got placebo. A really central part of the design was the glucocorticoid taper schedule. It was different for each group and pre-planned.
Right. The Upadacitinib arms had a faster taper, aiming to get patients off steroids by week 26. The placebo arm had a slower 52-week taper. That difference is key for assessing the steroid-sparing effect.
Precisely. Now, looking at the numbers, 428 patients were randomized and actually received treatment. That broke down into 209 in the 15 milligram Upadacitinib group, 107 in the 7.5 milligram group, and 112 receiving placebo.
And were the groups similar at the start?
Yes, the baseline characteristics look pretty well balanced across the three arms. About 70% had new onset disease. Most patients were women, and the average age is right around 71 years old. The average starting glucocorticoid dose was also similar, roughly 35 milligrams per day across the board.
What about people dropping out of the study? Did that differ between groups?
It did. The discontinuation rate was highest in the placebo group, 36.6% stopped treatment early. That compares to 31.8% in the 7.5 milligram group and 25.8% in the 15 milligram group. The paper mentions reasons like side effects and lack of efficacy being more common drivers for stopping in the placebo arm. They also note the potential impact of COVID-19 and tocilizumab becoming available outside the study.
Let's get to the main results then. What was the primary endpoint and what did they find?
The primary endpoint was achieving sustained remission at week 52, and this was defined quite strictly. No signs or symptoms of giant cell arteritis continuously from week 12 all the way through week 52, plus sticking to that planned glucocorticoid taper.
And the bottom line result?
For the Upadacitinib 15 milligram group, 46.4% of patients hit that primary endpoint of sustained remission at week 52. In the placebo group, it was 29.0%. This difference was statistically significant. The p-value was 0.002. So clear superiority shown for the 15 milligram dose versus placebo.
What about the lower dose, the 7.5 milligrams?
So in that group, 41.1% achieved sustained remission. But because of how the statistical testing was set up, the hierarchy that used this result wasn't formally tested against placebo for superiority on this primary endpoint. So no formal claim of superiority could be made for the 7.5 milligram dose based on this endpoint. But they did look at a range of key secondary outcomes, especially comparing the 15 milligram dose against placebo, which gives us a fuller picture.
Like sustained complete remission. How did that look?
Right. That adds the requirement for normalized inflammatory markers, ESR and CRP, on top of clinical remission and taper adherence. For that, 37.1% in the 15 milligram group achieved it, compared to only 16.1% in the placebo group. Again, a big difference, highly significant, with a p-value below 0.001.
And the steroid-sparing aspect's a really crucial goal.
Absolutely. And the data here is quite striking. If you look at the total cumulative glucocorticoid dose patients received through week 52, the median amount was much lower in the 15 milligram Upadacitinib group, 1,615 milligrams. Compare that to the placebo group's median of 200 to 882 milligrams. That difference was also highly statistically significant, p-value below 0.001. It really translates to needing a lot less steroid over the year.
Fewer flares, too.
Yes, significantly fewer. In the 15 milligram group, 34.3% experienced at least one disease flare during the 52 weeks, whereas it was 55.6% in the placebo group. The time it took to reach the first flare was also longer with Upadacitinib. This difference in flare rates was significant, p-value 0.001.
And getting patients off steroids completely.
That's a really practical goal, isn't it? At week 52, after finishing their planned tapers, 50.2% of patients in the 15 milligram Upadacitinib group were in complete remission and off glucocorticoids. That's compared to just 19.6% in the placebo group. Again, highly significant, p less than the 1.001.
Did they also look at how patients felt, patient-reported outcomes?
They did, yes. And the 15 milligram Upadacitinib group showed significant improvements compared to placebo there as well. They reported greater improvement on the SF-36 physical component summary score and a larger reduction in fatigue based on the FS fatigue score. The p-values were 0.002 and 0.004, respectively. So it seems the clinical improvements were reflected in quality of life and fatigue levels.
Okay, let's switch gears to safety. What did the profile look like over that 52-week period?
Generally speaking, the safety results reported over the 52 weeks were broadly similar between the Upadacitinib groups and the placebo group.
What were some of the more commonly reported adverse events in the 15 milligram group?
Looking at the 15 milligram arm, common things that came up during treatment included headache that was about 16.3%. Arthralgia, joint pain, was 13.9%. Hypertension was seen in 13.4%, and COVID-19 infection was also reported in 13.4%. The paper also specifically tracked adverse events of special interest things, often watched with this class of drugs or important in this patient group.
How about serious infections?
Interestingly, the rate of serious infections was actually numerically higher in the placebo group, 10.7%, compared to 5.7% in the Upadacitinib 15 milligram group.
And shingles, herpes zoster.
That was more frequent with Upadacitinib 15 milligrams. It occurred in 5.3% of those patients versus 2.7% of the placebo group. The paper does mention two specific cases of serious herpes zoster affecting the eye ophthalmicus in the 15 milligram group. Other events they watched: creatine kinase elevations were higher with 15 milligrams of Upadacitinib, 2.9% versus 0% with placebo.
Now, with JAK inhibitors, major adverse cardiovascular events, or MACE, are always a point of focus. What did this trial show?
So during the 52-week trial period, the paper reports two MACE events occurring in the placebo group. Importantly, none were reported in either the 7.5 or 15 milligram upadacitinib groups during that 52-week time frame. Now, while that's encouraging within the trial's duration, we have to remember this is just 1 year of data. The ongoing expansion study is needed for a clearer picture of long-term cardiovascular risk.
And blood clots, venous thromboembolism.
The rates there looked pretty similar across all three groups, somewhere between about 3.3 and 3.7%.
Any signals regarding malignancies?
The incidence of cancers, not counting non-melanoma skin cancer, was generally similar between the 15 milligram upadacitinib group and placebo. Non-melanoma skin cancer rates were also similar between the 15 milligram placebo groups, and actually numerically lower in the 7.5 milligram group. Importantly, they reported no cases of active TB, lymphoma, or GI perforations in any group.
Were there any deaths reported during the study period?
Yes, there were 4 deaths reported during what they defined as the treatment period up to 30 days after the last dose. 2 were in the placebo group, and 2 were in the 15 milligram upadacitinib group. For the 15 milligram group, 1 death was attributed to COVID-19. The other cause was listed as unexplained. The paper also mentions 1 additional death from a stroke in a patient who had received the 15 milligram dose, but this happened more than 30 days after their last dose, so outside that defined treatment period.
Okay, let's synthesize this. What are the main practical takeaways from SELECT-GCA for neurologists who manage giant cell arteritis?
Well, the headline finding really points towards a potential practice change. Upadacitinib 15 milligrams, used with that faster 26-week steroid taper, proved superior to placebo with its slower 52-week taper. Critically, it led to significantly higher sustained remission rates and, maybe just as importantly, allowed for substantial glucocorticoid sparing.
And that directly tackles a huge issue, right? The burden of long-term steroids, especially in older folks often dealing with diabetes, osteoporosis, hypertension. The potential to get patients off steroids by 6 months instead of a year while keeping the disease controlled, that median cumulative dose difference really highlights that benefit.
Exactly. And the safety profile seen here, within the 52 weeks, seems generally consistent with what's known about upadacitinib from other indications. Yes, you need to monitor for things like herpes zoster, and the long-term cardiovascular picture needs more data from the extension study, but the safety findings within this trial window are quite informative.
Plus, the fact it's an oral medication, that's relevant too, isn't it?
It really is. For many older patients, maybe with vision problems or dexterity issues or other things that make self-injection tricky, having an effective oral option could make a real difference in terms of adherence and just ease of use.
The paper did mention strengths and limitations, as good studies do. Let's touch on those briefly.
Sure. Strengths definitely include the rigorous design, placebo-controlled, double-blind, also the decent sample size for a relatively rare disease, including patient-reported outcomes, and the international nature, which helps with generalizability.
And on the flip side, limitations.
They noted the discontinuation rate was higher than they'd perhaps expected, maybe partly due to the pandemic or to tocilizumab access outside the trial. Also, the study didn't include patients who'd already failed an IL-6 inhibitor, so we can't extrapolate these findings directly to that group. How they assessed steroid-related side effects relied on investigator reporting, which can have some subjectivity. And as we've said, the need for longer-term safety data, particularly on cardiovascular events and maybe malignancies, is something the authors themselves point out.
So, wrapping up the trial itself, SELECT-GCA provides pretty compelling evidence that upadacitinib 15 milligrams can be a potent steroid-sparing strategy for getting and keeping giant cell arteritis in remission.
It certainly looks like a significant potential addition to our toolkit for managing this difficult disease, offering another therapeutic pathway to consider.
Which really leads to the key question for you, the practicing clinician listening. How might these findings influence how you approach treatment decisions for giant cell arteritis? How will you balance this potential for faster steroid tapering and sustained remission against the known risks associated with JAK inhibitors, like the herpes zoster signal? The need for ongoing safety monitoring when you're tailoring therapy for individual patients.
That's exactly the kind of complex clinical reasoning these new data prompt us to engage in.
Thank you for joining us on this deep dive into the SELECT-GCA trial results as published in the New England Journal of Medicine. Just to reiterate, this was an educational summary based solely on this specific paper.
And we absolutely encourage you to read the full original article yourself for all detailed methodology, complete results, and the author's full discussion.
Until next time on the Weekly Neurology Deep Dive.